And it's a great pleasure to introduce Dr. John Lipham. He is the chief of the Division of Upper GI and General Surgery and professor of surgery at the Keck School of Medicine of USC. He was the inaugural president of the American Foregut Society, and he's also the director of the USC Digestive Health Center and serves as a foregut cancer program director and chief of the affiliated academic programs in his region. His focus is disease of the esophagus and stomach, both benign and malignant, and amongst others, his main clinical and research interests are diagnosis and treatment of GERD, hiatal hernia, Barrett's esophagus, esophageal motility disorders, achalasia, and malignancy of the esophagus and the stomach. So he's well set to be part of the ISDE setting and this particular online session. And he will address what I think is relevant to all of us when to consider surgery. John, the floor is yours, or the screen is yours, I should say.
I'll take it either way. First, I will attempt to share my screen, which seems to be the most challenging part of any talk. So if someone can let me know that they actually see my slides, that would be wonderful.
It's perfect, we see it.
All right, step one. Well, thank you for the over-embellished introduction, and thank ISDE for inviting me to speak. I rarely get invited to much of anything. I don't even get invited to my dinner at my own house, so this is an honor to say the least. What I'm going to talk to you about today is really when to consider surgery, more importantly, really more about what constitutes the barrier to reflux. First and foremost, no talk is complete without a good set of disclosures. Here are two of my disclosures. Probably the most important disclosure that I really can list here is I am about as inbred Tom DeMeester as they come. I was his intern, his resident, his fellow, his junior partner for about 10 years before he retired. So if there's anybody that's got a little bit of a skewed view of the world, it's probably me, and that probably will be evident throughout this talk. So again, I was asked to talk about when to consider surgery for GERD. Well, for me, I think this question really answers itself. The question answers itself, I think, if we have a better understanding of what constitutes that barrier to reflux. What prevents somebody from having reflux? I also think the question answers itself if we have a palatable option for this disease. And so I think most of us will admit that, reflux is a mechanical problem. It is a mechanical problem, just like that leaky faucet at home. But I think over the last 20 to 70 years, that the only hesitation to really accept that it's a mechanical problem and accept a mechanical solution to the problem has been our poor reputation of our one and only treatment for the disease, which has been the Nissan fundoplication. I'm sure you're all familiar with the Nissan fundoplication, but over the years, and especially with the power of Dr. Google, the Nissan has gotten a pretty bad reputation. Online, there's definitely some safety concerns with the operation. There's question about durability of this operation. I will tell you there are huge variations in how the Nissan fundoplication is performed, which results in huge variations in the outcomes of this procedure. There's also this question of applicability to the GERD population. We as surgeons, I think we try to minimize it. I sit down with a patient and I tell them I'm going to do it through little bitty incisions. It's going to take me about an hour. They're going to go home the next day. It's not a big deal, but we are rearranging the anatomy. We're taking the short gastric vessels down. We're wrapping the stomach around the end of the esophagus. And so for many patients, this may be a little bit like that fly in the hammer analogy. Now, the bigger issue with the Nissan fundoplication, and here's where the power of the internet and Dr. Google comes to play, has been the reputation of its side effect profile. If you're a patient and you go online and look up Nissan fundoplication, go to one of the information or GERD blogs, you will find some pretty straightforward, what they consider facts. And that fact is, if you have a Nissan fundoplication, you're not going to be able to vomit. You're going to be bloated to beat the band, and you're going to be able to fly yourself to the moon with the flatulence that's created by the operation. So I can tell you as a surgeon, I believe in the Nissan fundoplication. It's a great operation to treat this disease, but unfortunately, more and more patients have a different view of this disease, which is really limiting their acceptance of having anything surgical to treat their reflux. And so despite this being a mechanical problem, I can tell you here at USC and under Tom DeMeester, you know, the whole world revolved around the lower esophageal sphincter. This was the whole disease. Every discussion, every meeting we had was in regards to what happened to the lower esophageal sphincter. And during those 20 years of living in the DeMeester camp, nobody mentioned a damn thing about anything else. And so I got to thinking, and that's always a dangerous thing for me to do, but I started to think to myself, you know, why on earth do the majority of these GERD patients have a hiatal hernia? You know, is reflux somehow causing this hiatal hernia? Is it some sort of cosmic coincidence? Or maybe the hiatal hernias are insignificant. They're unrelated to the disease. And then I really started to do the unthinkable. And I don't recommend doing this, but I started to read the literature. I started to read the literature on what constituted the GERD barrier. What was preventing some people from having reflux and why other people were not getting reflux. And so here's a little brief history lesson. So stay with me if you can. But the whole discussion about the barrier to reflux really began with a guy by the name of Phil Allison. Everybody associates it with Nissan because of the Nissan fundoplication, but it actually started about 5 years earlier with Allison, who was a thoracic surgeon out of England, who thought the barrier to reflux was really analogous to the other end of the body, to the anorectal junction. He thought the crura of the diaphragm were functioning very similar to the puborectalis at the other end. And this right here is his original publication that outlines that comparison between the puborectalis and the crura of the diaphragm. Allison really didn't think there was much of a lower esophageal sphincter. And the reason he didn't think there was a lower esophageal sphincter is because as a surgeon, you really don't see any thickening of muscle there. You don't see a discrete band of muscle that you could call the lower esophageal sphincter. So Allison's treatment to fix this disease was to fix what he saw as the underlying problem, which was the crura of the diaphragm or the hiatal hernia. And so Allison would go in transthoracically, he'd fix that hiatal hernia, he'd tighten up the crura, and lo and behold, that was his treatment, and his treatment was about 50% successful. He reported his first 33 patients, and what he reported was that 50% of them were better. And it gets to this idea that it's really a two-sphincter hypothesis, meaning there's two components or two sphincters that act to prevent reflux. This right here is a publication by one of my old fellows, Brian Louis, who's up at Swedish Hospital here in the US, where he did a fascinating study. He did intraoperative high-resolution manometry as he was fixing the hiatal hernias and doing a Nissan fundoplication. He would do the high-resolution manometry at various stages of the procedure so he could tease out the contribution to length and pressure that we see on manometry. And the results of this were really quite surprising. What he found was that increased length that we see on manometry, part of it or almost half of it came from him fixing the hiatal hernia, establishing or reestablishing the integrity of the crura. What was more surprising was when he looked at the increased pressure that we see on manometry. If you had asked me prior to this publication, I would have said, well, that increased pressure, all of it comes from me doing the Nissan fundoplication. But what he found was pretty much the opposite, that the vast majority of that increased pressure we're looking at on manometry comes from me fixing the hiatal hernia, restoring the integrity of that crura. And so, you know, I went to Dr. DeMeester and I said, listen, Dr. D, I don't think it's all about the lower esophageal sphincter. There seems to be more to this story. And he said, well, John, that's fascinating, but you know, it's not true. So, you know, really what you need is you need to put together a biomechanical model to prove to me that there's more to this story than the lower esophageal sphincter. So you probably don't know this, but I was a math major in college. And so I have people, I know people, I called my people, I called engineers and I said, listen, guys, we need a biomechanical model of what is the barrier to reflux. And so my guys got together. Now these aren't doctors, these are smart people, these are engineers. So they got together and formulated a biomechanical model of what constituted the GERD barrier. Now, I'm not going to pretend like I know or understand the vast majority of this publication. It actually took me about 3 weeks to get through the 3-page manuscript. But I will tell you, they used some pretty high definition and fancy cross-sectional imaging during this study. They used something called the governing equations of finite deformation elasticity. I have not a clue what that means, but it sounded incredibly impressive. And then in addition to that, they used a whole crap load of math equations. I mean, this paper was just filled with math. And as you can clearly see from this top math equation here, the barrier to reflux is both the lower esophageal sphincter and the integrity of the crura. I mean, it's plain as day. Now, lucky for me, being a lowly surgeon, they also had color images. And the color images show it even better, that barrier to reflux was both the crura of the diaphragm represented in green and the lower esophageal sphincter represented in blue. In fact, what they showed was both are contributing about 50% to that barrier against reflux. Now that looks vaguely familiar to what Allison had published some 50 years prior, where the crura of the diaphragm were analogous to the pula rectalis. So in short, the barrier to reflux is really both the crura of the diaphragm, or not having a hiatal hernia, and the lower esophageal sphincter. And these two things need to overlap in order to provide that barrier. This publication right here, which just came out a few years ago, looked at that very concept of whether these two sphincters need to overlap. They looked at 30 patients that had hiatal hernias and Barrett's esophagus, and they compared it to a control group. And using endoflip technology, they were able to look at that barrier. This right here represented on the screen is the healthy controls. And what we see on endoflip here is the distensibility there is very low, with overlap of that crura and lower esophageal sphincter. They then looked at the GERD patients, or the patients with Barretts. And what they found here was separation of those two sphincters. Now the lower esophageal sphincter and the crura of the diaphragm no longer overlapped in patients with reflux. And they saw a spectrum of this, a spectrum of the separation for sizes of the hiatal hernia. They also saw a spectrum in decline in each one of those components. So in other words, reflux was caused not only by deterioration of the lower esophageal sphincter, but also deterioration of the crura of the diaphragm and separation of those two sphincters. And what they really found was that once you got to about 3 centimeters of separation, you've really lost all of that overlap. And those are the patients that really started to have problems. And so this separation or having a hiatal hernia is actually quite common. It sort of came up a little bit in that last discussion. But for a reflux patient, the vast majority of them have hiatal hernias. This is a study that looked at that very question. What is the incidence of hiatal hernias in the GERD population? And so they looked at 600 and some odd GERD patients. About 350 of them had NERD, 273 had esophagitis or Barrett's, and they compared that to a control group. And what they found was, yes, indeed, hiatal hernias are common in the GERD population. In fact, if you look at all GERD patients in general, it's upwards of about 70% of them are going to have a hiatal hernia. Even in the NERD patients, the patients without injury to the esophagus, 60% of them had hiatal hernias. Patients with esophagitis, that rate now is up to 80%, and in Barrett's esophagus, it approaches 90%. Whereas you look at a control population of people that don't have reflux, and that incidence was very low. Again, what they found was that in patients with hiatal hernias greater than 3 centimeters, again, you've lost all of that overlap in the two sphincters. The incidence of esophagitis and Barrett's was significant. And why is all this important? Well, it's important because in order to treat this disease, we need to understand what we need to treat. And so there's two problems here, or two parts of this disease, because again, it's a mechanical problem. That barrier is both the lower esophageal sphincter and the crura. And so if we're going to treat this disease, we've got to treat both parts. Part one is to fix the hiatal hernia, to restore that integrity of the crura, or that first sphincter. And then part two of this disease is to fix the lower esophageal sphincter. And so it begs the question, at least for part one, does the size of the hiatal hernia matter? And I would argue, well, the size of the hernia doesn't really matter a bunch anyway. because I will argue that the crura of the diaphragm are defective in all patients with a hiatal hernia. You know, the hiatal hernias are forming because the crura are defective. Meaning you just don't wake up one day with a 5-centimeter hiatal hernia and normal crura of the diaphragm. The reason that hernia formed is because the crura have deteriorated. And as the crura deteriorate further, the hiatal hernias become bigger and the reflux becomes worse. And at some point, you will have lost 50% of that barrier. And so it begs the question, what is a significant hiatal hernia? Well, this is an interesting study from I believe Sweden, where they looked at 360 people in the general population. Somehow they were able to get them to do symptom questionnaires as well as consent for an upper endoscopy. And what they found in this study was that patients with hiatal hernias greater than 2 centimeters, those are the patients that started to become symptomatic from their reflux. This is also a very progressive disease. This study right here by Marco Patti, who's a well-known foregut surgeon here in the United States, looked at the size of the hiatal hernia and whether that impacted the severity of the disease. So we looked at 175 patients. They were all pH positive. They all had the normal workup that we put the GERD patients through. He broke it down into 4 different groups. Patients that had reflux but didn't have a hiatal hernia. They had hernias less than 3 centimeters. Patients with hernias 3 to 5 centimeters, and then greater than 5 centimeters. He then looked at the severity of the disease. And what he found was this: as the hernia size increased, the Meester scores or pH positivity rates went dramatically up. The incidence of esophagitis also went significantly up as the hiatal hernia got bigger. The incidence of Barretts went up, again, as the hiatal hernias got bigger. And the percentage of patients having a hypotensive barrier also went up as the hernias got bigger. Additionally, he found that respiratory symptoms were more common in patients with the bigger hiatal hernias. So in other words, the bigger the hiatal hernia, the worse the reflux. Now in his study, the inflection point again seemed to be right around that 3-centimeter mark. If you look at these bar graphs here, once patients get to a hiatal hernia of about 3 centimeters in size, they're much more likely to have esophagitis, Barrett's, and pretty high de Meester scores. Now, part 2 of this discussion, and I don't have time to go into all this, but is to fix the lower esophageal sphincter. I will preface it by saying that's assuming that the hiatal hernia component of this has been fixed. The Nissan fundoplication is one option, albeit the reputation is a bit prohibitive, at least here in the United States. More and more patients don't want it. Partial fundoplication seems to be our go-to nowadays. It does have a little bit better side effect profile. The TIF procedure, which we haven't talked about here today, but is also another option, and I will say an actually pretty good option at restoring the lower esophageal sphincter and doing a endoscopic partial. The Stretta procedure is another option for patients. And then something called the Lynx device. If you're not familiar with the Lynx procedure, it's a little bracelet of magnetic beads that we place around the end of the esophagus. The force of attraction of those magnets wanting to come together keeps that lower esophageal sphincter closed. The force of a swallow, belching, or vomiting will cause the beads to open to control reflux. So the best question, I think, for the day is really, who are these hiatal hernia patients? Well, in short, they tend to be the patients with regurgitative symptoms. Regurgitative symptoms are very difficult to control with medical therapy. Multiple studies have shown that PPIs are minimally effective at controlling regurgitation for these patients. This right here is a study that we did a couple of years ago looking at the use of Lynx in regards to control of regurgitative symptoms. If you're not familiar with it, it was a randomized controlled trial. 50 patients, all pH positive, all had typical reflux symptoms, as well as regurgitative symptoms. 50 patients were randomized to get the Lynx device. 100 patients were randomized to BID PPI. We had the patients come back at 6 months. They underwent the normal symptom questionnaires. More importantly, they also underwent impedance pH testing. Primary endpoint of the study was regurgitative symptoms, and what we found here is the patients that were randomized to Lynx, almost 90% of them had complete elimination of their regurgitative symptoms, whereas those patients that were randomized to BID PPI, that was only about 10% had improvement. We also looked at GERD HRQL scores or symptom scores, and what we found here is the patients that were randomized to LINX were significantly better off. And in fact, 92% of the patients that were randomized to LINX were able to stop their PPIs completely. We also looked at pH normalization rates, and what we found here was that across the board, no matter how we defined it, about 90% of the patients were now normal, whether that was by number of episodes, Demeester score, or percent time pH less than 4, patients were now normal. So I think this is one group of patients that can clearly be identified as a group that may need some sort of surgical intervention, is the regurgitative patients. The other group of patients is probably those Barrett's patients. This is an interesting study right here by Sri Kamandori out of Northwestern, who's a well-known gastroenterologist, who looked at Barrett's eradication and recurrence rates after ablation. Traditionally, if you follow the literature, the recurrence rate after ablation of Barrett's can be as high as 30%. At Northwestern, they instituted a very strict reflux management protocol. I won't go through all the details of that, but basically it was assuring patients had good reflux control on medical therapy. They then compared that to a group of patients that they sent for a Nissan fundoplication and looked at the recurrence rate of the Barrett's. Even in their hands, which I would consider the best of hands in regards to controlling reflux medically, what they found was the patients that got a Nissan fundoplication, the recurrence rate of the Barrett's was only 4.9% compared to almost 11% in the medical arm. They did a multivariate analysis to predict who was going to recur. And of course, the patients with hiatal hernias fell out as the highest risk for recurrence of their Barrett's. We've also looked at LINX in regards to the Barrett's patients. This publication came out just a couple of months ago, looking at patients with gastroesophageal reflux disease and Barrett's esophagus. We looked at 87 patients. Mean follow-up after having a LINX procedure done was 2.3 years. The majority of these patients were short and ultra short segment Barrett's. We looked at pH scores postoperatively, and what we did is, or what we found was, we took patients with a median Demeester score of 34 and brought that down to 13.7 in this group of patients. We also looked at Barrett's regression rates. If you follow the Nissan literature, you'll find regression rates of short segment Barrett's of upwards of 40%. What we found was regression rates of around 60%, so a little bit higher than the Nissan group for unclear reasons. Even when we looked at patients that had had more than one endoscopy, so 2-3 years of follow-up endoscopies, the regression rate was still around 60%. And then a handful of patients, about 7 or 10 patients out beyond 5 years, the regression rate was still quite significant. We did not see any progression to dysplasia or esophageal cancer during this period. And so in summary, I think I've overshot my time. When to consider surgery? Well, I think it's pretty straightforward. You know, again, if you recognize that the GERD barrier is both the curve of the diaphragm and the lower esophageal sphincter, you know, surgery for the GERD patient is really going to be when they've had significant failure of that GERD barrier. Because again, the crura are 50% of this issue here. And so significant failure, at least in my mind, are the patients that have developed a hiatal hernia, especially when that hiatal hernia has gotten upwards of 3 centimeters or so. These are the patients that are much more likely, as I've shown you, to have esophagitis, to have regurgitative symptoms, and Barrett's esophagus. The palatable treatment for this, like I said, at least here in the States with the power of Dr. Google, our palatable options are really the LINX and one version or another of partial fundoplication. So with that, I am going to stop my babble and see if you have any questions.
Thank you for a very clear presentation. There's a couple of questions already. So one that is addressed to the Scandinavian study you presented, but could also be taken in general. The question is, how was the length of a hiatal hernia determined there? Because we all know that there's no good gold standard. And for instance, if you do this at endoscopy, the rate of inflation that you impose will actually diminish or make it bigger, the size of the hernia. So what do you consider the gold standard, or how would you recommend any colleague to assess the size of a hernia?
Yeah, that's a great question. You're right. There is no gold standard, and there's not a lot of correlation either between endoscopy and barium swallow and manometry. So, for us, I agree with you. Endoscopy is not a great way because you can reduce the hernia, you can insufflate the stomach and make it look even bigger on retroflex view. Generally, what we'll do here at USC is we rely on either barium swallow to determine hernia size, or what I think is really probably the most accurate is manometry in determining at least the axial disruption of that.
Mm-hmm. Yeah, and as a follow-up on that, the focus in the hiatal hernia assessment is on the axial displacement, but there's also a lateral impact. I mean, you have patients in whom you have a hernia, but still some narrow supradiaphragmatic segment, still a sphincter area that is close around the endoscope, but then you have others where it has really widened. So does that change your approach? Would you do anything differently in choosing the type of intervention? Are some of them better for the links or worse for the links compared to the modified fundoplications or incomplete partial fundoplications that you proposed? What would be your choice there?
Yeah, I think that's probably the best question of the day, because you're right. What matters most in these patients is probably that radial separation of the crura. For decades, we've used the axial disruption of the hiatal hernia as our marker of severity of disease, if nothing else, and I think that's wrong. The most important thing is that radial separation, because the further away the crura get, the less they can contribute to that barrier. The problem we have is we don't have a great way of measuring that preoperatively, that radial separation. The best we can do is on endoscopy, trying to see where that pinch is and how far apart it is. But I think you're absolutely right. That's much more important than the axial disruption.
Mm-hmm. Well, maybe the endoflip would help there, but I think that remains to be explored. The device that you showed from the Danish study, maybe it helps there. I think we have a few minutes time, and I'm the only non-speaker, so I will do an effort to try and have an opinion for every speaker. Let's say you have a 30-year-old patient, not too obese, has been functioning well with chronic reflux disease, no Barretts, no complications, and is good on a twice daily PPI dosage. And the patient comes and asks, doctor, can I continue taking in the morning and the evening a PPI, or should I consider something else? And I'm going to go around. I'll go to Dr. Dunbar first. Will you send the patient for surgery or other procedure, or will you say, why don't you keep on the PPI? Then I'm going to go to Dr. Inoue and then to Dr. Lipham. Kerry, you're first.
So for your average 30-year-old, there are a few more things that I would want to know. So he's responding to PPIs twice a day. I would also want to talk to him about diet and lifestyle changes and make sure he's not drinking 10 cups of coffee a day or some other factor that would allow him to drop, that if we could correct, he could drop down to once a day.
Yeah, I was thinking I did by saying he's not obese. So I think in the terms of lifestyle, there's not a lot to gain.
Not a lot to do. That's a long-term PPIs. And so it sort of just depends. There are some of my patients that I see really don't want to have surgery, and they would do anything to not have surgery. And then other people, it just depends where their risk tolerance and what they're most concerned about. So certainly if, this particular patient doesn't have a whole lot we can do with diet and lifestyle, but for some of my patients, there would be a lot of discussion about that. I would also want to know if he has some sort of anatomic issue. I mean, if he has a giant hiatal hernia, or, that would also push me towards sending him to go for a surgical evaluation. But a lot of it's just a risk benefits discussion and a discussion of like how to manage long-term with the patient.
Yeah, and so the patient's view is also very important, I understand.
Yeah.
Okay. Dr. Inoue, what would you do with a patient who is well controlled with slightly elevated dose of PPI? Would you say, I would recommend an endoscopic procedure, send you to a surgeon, or for a modified anti-reflux surgical procedure, or continue the PPI?
Yeah, it's a tough question. So age of 30s, that's the point. Age of 30s.
Yes.
So you mentioned the yellow, so must be a Japanese, but anyway. So age of 30s is a point. So we have to carefully discuss with the patient. So without hiatal actual deviation, so we can apply anti-reflux mucosal ablation, ARMA procedure. We can apply. But so it depends, of course, yeah, esophageal motility, we have to check it. Esophageal clearance, we have to check it. But anyway, so 50% of the ARMA patient who receives the ARMA procedure reduce the PPI successfully. Half of them stop PPI. So we want to recommend ARMA procedure, but age of 30s, and his diet habit is another important issue. If we take lots of meal, so I recommend a very quick meal he take, then so I carefully recommend, it's difficult. So Nissan fundification floppy is another choice. Okay. So carefully discussion with the patient.
Okay, Dr. Lipham, what's your view?
Well, it comes down to quality of life. If the patient's well controlled, you're not going to make a good patient better. And so for me, it always comes down to quality of life. If they're doing great on their meds and they're not interested in getting off their meds, what we usually will tell them is come back to us in 3 to 5 years. Let's see how you're doing. Maybe do an endoscopy to see if we've had any damage to the esophagus. But we definitely don't force the issue in somebody that's well controlled. That's a recipe for disaster.
So I understand from that that as a surgeon, you're not that worried also about chronic PPI use.
No, I agree with Kerry. These studies are largely crap. They're epidemiologic and
great to know. Then I think I have another question, particularly for you. Do you think that the type 3, type 4 paraesophageal hernia is part of the spectrum of reflux disease, or should it be considered as a separate entity?
No, I think it's the spectrum of the disease. I think, you know, we have an arbitrary classification system in regards to hernias, but it's all part of the same disease. It's failure of the diaphragm. And we've tracked a number of patients. It's interesting, we should publish it, but we've got about 20-year data of patients that have come in because we follow even the medical therapy patients. And they've started off with 3-4 centimeter axial hernias. 15, 20 years later, now we're seeing them and they've got true paras. So I'm pretty convinced it's a spectrum.
I think there's a lot of scientific work to do on the hernia. I mean, we all know the mechanical factors, abdominal obesity, playing a wind instrument where you set a lot of pressure, but there must be genetic predispositions. And it's amazing for such a common disease that this has not been unraveled actually to date. That's a little bit surprising, I think. You identified the regurgitation patient as a most suitable candidate, and I think Dr. Dunbar will probably agree that that PPI therapy will not address this, and I don't think we have a medical treatment for that. But to Dr. Inoue, I would like to ask for regurgitation, you know, volume reflux, persisting under PPI, maybe being non-acidic, but still the volume is coming up. Do the AMRA or AMERS procedures, do they cover that as well? They seem to be approaching the opening of the sphincteric segment. Do they also control regurgitation? Do you have any data on that, Dr. Inoue?
No, still the number of procedures limited, and at this moment I have no answer to that. But so we are thinking like that. So so by the arms or armor procedure, we can tighten the open hiatus. So that may reduce the total volume of a reflux. But still the number of the patients is limited. So the purpose of the procedure is a rebuilding of the mucosal flap valve. The concept is very similar to not just surgical, not equal to surgery, but anyway. So morphological improvement, we can get it. Okay. But I cannot answer to your question at this point.
Last short question to Dr. Lipham. What about using a mesh during crura repair? Which patient and any preference for an available mesh?
Short answer, not a big mesh believer. It's not been shown to decrease long-term recurrence rates. It may kick the can down the road and prevent short-term recurrence, but at least the currently available meshes have not been shown to decrease long-term. So the only time we'll use mesh is maybe in a redo case, but even then, I don't think it does anything.
Okay, very good. I think that puts us on the spot of the timed end of this session, which I enjoyed quite a lot. I would like to thank all the three speakers for giving excellent state-of-the-art, up-to-date and interesting presentations. I learned a lot, and that is the goal. And I hope for the audience, who I like to thank for being present here and for asking questions, I hope they have the same experience. Thank you, everybody. Enjoy the day. Stay safe and hope to see all of you somewhere in the course of next year, face-to-face. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye.